So this is the last presentation of the day. After wonderful presentations on facial plane block with ultrasound guided technique, this is with landmark guided technique. So we all know that it becomes a breaking news when we hear that there is no ultrasound, there is no PNS, and the anesthetic is giving facial plane block. But actually, it is not a breaking news. Anybody can block. So any anesthetist can give block, facial plane block, if he or she knows about certain techniques, certain concept. It's very easy to give facial plane block with landmark guided technique. So which blocks you can give with landmark guided technique? We can give lower limb block like fascia iliaca block, abdominal wall block like tap block and rectus block, chest wall blocks like thoracic paravertebral block, PAX block, and SFP blocks. So all these blocks can be given with landmark guided technique. What you need is local anesthetic drug like bupivacaine or ropivacaine or silocaine with ethylene or whatever drug of your choice, and syringe and needle. So for lower limb blocks, we can give fascia iliaca compartment block. For abdominal wall block, as I said, tap block and RSP can be given. If we talk about anatomy of abdominal wall, it is supplied by T6 to T12. And if you see this diagram here, you can see T7, T8, and T9 enter just below the posterior margin in the abdominal wall between internooblique and the transverse abdominis muscle. So if you inject the drug in this subpostal area between transverse abdominis and internooblique muscle, it will block T7, T8, and T9. If you go laterally between costal margin and iliac crest and inject the drug in same plane, you will block T10, T11, and T12. And if you go just above the iliac crest, you can block ilioinguinal iliohypogastric nerve in tap plane. So classical tap block was described bit posteriorly in the petit triangle. Petit triangle is formed anteriorly by the posterior border of external oblique and posteriorly by the anterior border of latissimus dorsi. So if you inject the drug here, you have two pop and it will block mostly T10, T11, and T12 along with ilioinguinal iliohypogastric, and sometimes it goes even beyond just like dual block. So you can use this classical technique, or you go in laterally in midway between the iliac crest and the costal margin, the mid-axillary line, but here you will block only T10, T11, and T12. So it is for below umbilical surgery only. As I said, for ilioinguinal iliohypogastric nerve block, you have to go just above the iliac crest where both of these now enter in tap plane. You have to, you can palpate anterior superior spine, go 5 cm cranial, go 5 cm posteriorly, fill the two pop and inject the drug to block, to give ilioinguinal iliohypogastric nerve block. For subpostal tap block, again, as I said, you have to go into subpostal area. So you have to go 2 to 3 cm anterior to the anterior axillary line. Again, fill two pop of externooblique and internooblique fascia and inject the drug in the tap plane, and you will block T7, T8, and T9. It can be used for upper abdominal surgery. So what we need to learn? We need to learn about concept of cushion effect when we are giving landmark guided blocks or LOR blocks. So what is loss of it is described in this article by Dr. Shiv Kumar Singh and M. Gullian Gurubai long back in 2011. So what is cushion effect? When you insert a blunt tip needle in the skin, there will be a resistance, because when you insert the needle in the skin, it is difficult to insert the needle. So you apply pressure, and when you apply pressure, subcutaneous tissue will get compressed with that pressure. And once you suddenly there will be giveaway, and along with fat and muscle, you will sometimes pierce a first layer of fascia also, and you are in the second muscle. So you miss the pop of first fascia, and you end up giving the drug in the wrong plane. So how to prevent cushion effect? You insert the needle in the skin, keeping the needle parallel to the skin. Then make the syringe perpendicular to the skin. Then fill the pop of first fascia. then of second fascia, and then inject the drug. So this is the pop of fascia, bounce and pop of the fascia, again bounce and pop and inject the drug. Other methods are make an incision in skin so that you don't feel the resistance of the skin, go through the skin, then feel the bounce and pop of the fascia, and then advance the needle to feel the pop of second fascia. You can use also needle through needle technique, like in spinal needle, which is pencil point spinal needle, where there is a sharp tip needle, outer needle. Through that, we can insert the blunt tip needle and feel the pops of the fascia. Or last but not least, we can withdraw the up to skin after initial. So insert the needle initially, then withdraw to the skin, then redirect a bit and feel the pop, and then insert the needle. So how to feel the pop and bounce? Here, this is a simple video. This is external oblique, this is internal oblique, and this is transverse oblique. So I'm in the external oblique fascia, feeling bounce and pop, then advance the needle. Again, I will feel the bounce and pop. Once I feel second pop, I will start injecting the drug, and it will spread in the tap plane. So this is how you can feel bounce and pop, bounce, bounce, pop, bounce, bounce, pop, and inject the drug. Various needles used to prevent cushion effect are like the you can use 2He needle, you can use pencil point spinal needle, you can blunt tip block needle also, but last but not least, you can use hypodermic needle also. So it is a very cost-effective needle. It is just 1 or 2 rupees needle, and in obese patient, you can always use spinal needle, which is also 100 rupees needle. So how to blunt the needle tip? There are various techniques like rubbing the needle inside the higher growth needle. This is simple technique by which you can make the needle tip blunt. Second technique is, this is a sterile bowl of LA. So I'll hit the needle twice or thrice inside the LA bowl, and it will make the needle tip blunt. So this is a very simple technique by which you can blunt the needle tip. You can use your own technique. So how to give LOR tap block? It is a very simple technique. Here we will see how to feel. This is a post-op patient of LSCS. I'm palpating the anterior superior spine. I will go 5 centimeter cranially and 5 centimeter laterally, and I will insert the needle and feel the pop to both block the ilioinguinal iliohypoglycic now in the tap plane. Here you can see I have marked the point. Then I am inserting the needle. Here you can see I'll go through the skin, then withdraw to the skin. I'll gently apply the pressure so that I don't miss the pops of the first fascia. So I'm withdrawing the needle again. Now I'm redirecting a bit and feel the pop of external oblique fascia. This is pop of external oblique fascia. So once I go through it, then I will feel the second bounce and pop of the internal oblique fascia, and this is the second pop, and then I will start injecting the drug. I'll inject 20 ml of 0.25% ropivacaine on the both side for LSCS. If it is hernia, you can give unilateral block. After every 5 ml of injection, always aspirate. And second important thing is always keep lipid inside OT, because last can happen anytime, and you should have intralipid inside OT whenever you are giving block. So after 10 ml of LA, you can see the backflow of the drug. If you are in the right plane, there will be nice backflow of the drug. If you are intramuscular, there won't be any backflow of the drug. So you can check it by this technique. So this is how you can give LOR tap blocks. Subpostal tap block, as I said, again, you have to draw the anterior line. This is subpostal margin. I will go 2 centimeter anterior to the anterior line and insert the needle and fill the pop too. Here you can see this is the first bounce and pop. Yeah, you can feel the pop. Now second bounce and pop. After 2 pop, I will inject the drug, and this block will act nicely. So this is how you can give subpostal tap block. It is very easy to give, and you can even confirm it with ultrasound after giving the block. Always follow the, here you can see this is the tap plane, and you can see the drug inside the tap plane. So this is how you can give the tap block. Rectus block is used for upper midline incision. You can give bilateral block give upper midline incision pain relief, or if it is paramedian incision, you can give a single side block. So here you can see this is the rectus sheath. This is anterior rectus sheath, posterior rectus sheath, and you have to deposit the drug below the posterior, above the posterior rectus sheath and below the rectus muscle. So here you can see this is the rectus muscle. This is anterior rectus sheath. I am filling the bounce, then pop and advance. You don't need to fill a second bounce. Once you feel the resistance, you have to inject the drug. So this is how you can give rectus sheath block. Here you can see this is the how you can give rectus sheath block. It is a very simple block and it can be given very easily with loss of resistance technique. So he's Mehul, he worked with me and he sent me this video after learning it from me. So insert the needle. He's doing this incisional hernia surgery solely under block. So patient is awake. So he's feeling the bounce of the anterior rectus sheath. Then you can see he's advancing the needle. Once he feels the second resistance, he will inject the drug. Through that, he is filling with 2 cc needle. Then he will take the 10 cc needle and inject the drug. You require 15 ml of LA on both the sides. So if you are doing bilateral tap and rectus sheath block, you require 20-20 plus 15-15, so 70 ml of LA. So you should dilute the drug. You can use 0.2% propylene and 70 ml so that you don't cross the toxic limit of the drug. You can see the backflow also. So this is how you can give rectus sheath block. For chest wall block, thoracic paravertebral block is age-old technique, and you can give it with LOR technique very easily. What you need to do is you have to mark the spinous processes you want to block, then go 2.5 centimeter lateral, insert the needle perpendicular to the skin, then hit the transverse process, redirect the needle cranially or caudally, preferably caudally, then go 1 to 1.5 centimeter beyond transverse process. Once you feel the pop of superior costal transverse ligament, you can inject the drug. So how to give it? This is a simple video here. You can see this is for this patient was for nephrectomy. We have marked the T8, T9, T10, and we are giving a T10. Here you can see I hit the transverse process. Then I am redirecting the needle caudally. We hit the transverse process at 3 centimeters, as this is a thin and lean patient. And here you can see this is the loss of resistance. Once we feel it, we started injecting the drug and watched on the ultrasound, and you can see this is superior costal transverse ligament and this is the pleura. These are the transverse processes, and drug is spreading nicely between two. So this is how you can give LOR thoracic paravertebral block. Erector spinal block is recently introduced since last 5-6 years in practice. It is similar to thoracic paravertebral block, but here you need to inject the drug on the transverse process only. So how to do it? Very easy block. So what you need to do, mark the spinous processes again, go to 3 centimeter lateral to it, hit the transverse process and just inject the drug. So it is a very easy block. So as I said, palpate T5, then go 3 centimeter lateral, insert the needle. Once you hit the transverse process, it is said that through costotransverse process, drug will slowly trickle into paravertebral space and it will give analgesia. It blocks dorsal root consistently, so you can use for posterior spine surgery in posterior incision. And it is said that drug goes and block ventral root also, so you can use for surgeries like breast surgery, renal surgery, or abdominal surgery also. So once you hit the transverse process, after respiration, inject the drug, and here we will see with ultrasound also that this is a transverse process and drug is spread nicely in the right plane. So this is how you can give ESP with a landmark guidance. You can give PEX block with LOR technique also. So this is a very simple technique. Here we will see that how to give it. So palpate the third rib, blunt the 24 gauge needle, hit the rib, withdraw the needle tip till skin, fill LOR of the prefector of fascia. Then at second resistance, you will be between PEC major and PEC minor, so it becomes your PEX 1. And after hitting the rib, withdraw a bit and inject the drug, where you will be between serratus anterior and PEC minor, so it becomes your PEX 2. here it is important to attach the needle to the attach the syringe to the needle all the time, because if it is open to air and if you accidentally puncture the pleura, there will be pneumothorax. So I will hit the rib first, then withdraw and inject till the pop of second. At the second pop, I will start injecting the drug and it will be in PEX1 plane. So here you can see I'm giving PEX1 block initially, then advance the needle and hit the rib. Once I am on the rib, here you can see I'm on the rib. I'll withdraw a bit and inject again for PEX2 block. Many of my friends using this technique with LOR and they are getting good results. So this is also again a very effective technique. So here you can see this is the drug between the PEC minor and serratus NPS, and you can see the drug between PEC major and PEC minor also. So we confirm it with ultrasound. Here this is PEC major and this is PEC minor, and drug is nicely spread in the plane. So this is how you can give PEX1 and PEX2 block. SAP block, again, it is very easy block. Draw the posterior axillary line, hit the fifth or sixth rib and inject the drug. It is as simple as that. So this is the mid to posterior axillary line. Then I will hit the rib. This is very obvious patient, so I'm locating the rib. You have to be careful to locate the rib. Always attach the syringe to the needle so that if you accidentally puncture the pleura, you don't go inside the pleura and create pneumothorax. So once you hit the rib, after respiration, inject the drug and you will see drug will spread nicely just above the rib and below the serratus anterior muscle. So this is how you can do LOR SAP block also. FICB, what you need to do is you have to mark the anterior superior iliac spine, then ischial tuberosity, divide into 3. At the junction of, mark the junction of medial 2/3 and lateral 1/3, go 2 centimeters below that, fill the pop of fascia lata first, then fascia iliaca and inject the drug. So here you can see I have marked the, this is anterior superior iliac spine, this is ischial tuberosity, this is junction of medial 2/3 and lateral 1/3. I am going 2 centimeters below it, and what I will do is fill the 2 pops. So I'm trying to fill the pop. You can see the second pop, and so when you inject the drug at first pop, you are in the fascia below the fascia lata, so you can block lateral cutaneous nerve of the thigh at that level, and after 2 pop, when you inject the drug, it will block femoral nerve. So with 2 pop technique, you can block both the nerve consistently. If you give after 2 pop only, then you require higher volume like 40 ml of LA to block both the nerve. But if you are doing with a 2 pop technique, then you can block both. Here you can see the bed flow also. So this is how you can give fascia iliaca compartment block also. So this is all about the block with LOR technique. What we need to remember is we have to understand the concept of cushion effect. Then second important point is always we have to reduce the concentration, because facial pain blocks are high volume block. And third important point is always calculate the dose according to the weight of the patient, then reduce the concentration according to your requirement. So this is all about facial pain block with LOR technique. Thank you very much.